Have you ever noticed those ugly varicose veins snaking across your legs? Or maybe you experience that persistent ache, uh, feeling of heaviness, or that nagging swelling at the end of a long day? It's easy to dismiss these things, isn't it? As just minor inconveniences, maybe a natural part of aging or even just a cosmetic issue. But what if there's actually a much more complex story unfolding beneath the surface, one that truly impacts your overall health and well-being? Today, we're diving deep into precisely the intricate world of our body's circulation. Specifically, we're focusing on chronic venous disease. We're going to unpack the recently updated European Society for Vascular Surgery, or ESVS 2022 clinical practice guidelines on the management of chronic venous disease of the lower limbs. And this isn't just some, casual update. This is what's a monumental document, meticulously crafted by leading experts from across Europe and beyond. It brings us the most comprehensive evidence-based guidance available right now.
Absolutely. And our mission here for you, the listener, is really to cut through the dense medical jargon. You know how it can make these guidelines feel almost impenetrable sometimes? We'll distill what's most important for you to know. Whether you're genuinely curious about your own leg health, maybe preparing for a conversation with your doctor, or heck, simply fascinated by the latest in medical science. These guidelines, they offer a much clearer roadmap, not just for understanding those visible varicose veins, but for appreciating the entire spectrum of chronic venous conditions. I mean, from those mild symptoms you might be feeling, all the way to serious, really life-altering ulcers that affect millions of people globally.
That's exactly right. Our goal is to basically arm you with a clear understanding. We want you to get the core concepts of chronic venous disease, the cutting-edge diagnostic approaches doctors are using now, and the wide array of treatments available, both conservative and interventional. We'll be highlighting what's truly new, what's shifted since the previous 2015 guidelines, and even give you a bit of a peek into the significant questions that future research aims to answer. Think of this as your personal shortcut, a way to be exceptionally well-informed about chronic venous disease, and maybe start understanding what your legs might be trying to tell you.
Understanding chronic venous disease, CVD. The foundation. Okay, so to really grasp how these conditions progress and how they're managed, we need to start at the beginning. How do doctors actually define and categorize them? Let's start with the absolute basics. What exactly is chronic venous disease, or CVD? The guidelines clarify that it's a really broad umbrella term.
It is, yeah. It encompasses any long-duration changes, whether it's structure or function, of the venous system. And these changes present with symptoms or signs that, they need investigation and care. So it's not just one thing, is it? It's a whole range of conditions affecting your veins over time.
That's a crucial point. CVD covers this huge spectrum. You can think of chronic venous disorders as the general term for any issue, from maybe minor cosmetic veins right up to serious skin changes. But when doctors use the term chronic venous insufficiency, or CVI, that's really reserved for the more advanced stages. That's where you actually start to see physical manifestations like, significant swelling, pronounced skin changes, or even those open ulcers we mentioned. Making that distinction is vital. It tells medical professionals about the severity, the progression of the disease. Are we looking at a mild disorder or a more serious insufficiency that needs, more aggressive management?
Right. And doctors, they love their acronyms, don't they? When it comes to CVD, CEAP is a big one. It stands for Clinical, Etiological, Anatomical, Pathophysiological. Sounds like a mouthful, I know.
It does a bit, yeah.
But it's actually the most widely used tool to describe CVD. You can think of it almost like a detailed report card, giving a snapshot of the disease at a specific point in time. It helps everyone involved in your care speak the same language.
Exactly. Like a detailed report card for your veins. It's a good way to put it. And the 2020 update of CEAP, that was a significant evolution. It made it even more precise. It adds new categories, for instance, to specifically track things like recurrent varicose veins or recurrent leg ulcers. So this means if you've had treatment and the problem comes back, doctors now have clearer ways to describe that specific situation. It also refines the categories for why the problem happened. Was it what they call intravenous, maybe started inside the vein after a blood clot? Or extravenous, maybe due to an external factor like a tumor pressing on a vein. This level of detail, it just allows for much more precise communication among clinicians and, importantly, better tracking of how the disease progresses over time.
Okay, so let's break down the CEP system a bit more then, because understanding even the basics can really empower you when you're talking to your doctor, right? The C for clinical describes what you or your doctor can actually see or feel. It ranges from C or 0, meaning no visible signs at all the way up to C6, which signifies an active venous leg ulcer.
A pretty wide range.
Definitely. And in between, you've got C1 for those telangiectasias, or reticular veins, the tiny spider veins and slightly larger blue veins.
Hmm.
C2 is for varicose veins, the more noticeable bulging ones. C3 indicates edema or swelling. C4 covers various skin changes like discoloration or hardening. And there's actually a new addition here, C4C for corona phlebiticata. Sounds fancy, but it describes a subtle fan-shaped pattern of small veins often seen around the ankle.
And the insight there is pretty interesting. It means that even these seemingly minor changes are now recognized as important markers of disease progression. They signal a need for closer attention, maybe even to the microcirculation. And importantly, for each of these clinical classes, C0 through C6, it's further specified with an S if you're symptomatic, meaning you feel pain, ache, heaviness, or an A if you're asymptomatic. So no symptoms despite the visible signs.
Got it. So C is what you see and feel. What about E?
Right. E is for etiological. That tells us the underlying cause. Is it primary, meaning it just sort of developed spontaneously without a clear external trigger? Or is it secondary, which often happens after something like a deep vein thrombosis, a DVT, or maybe due to external compression? There's also congenital, indicating it was present from birth due to a malformation, or simply none identified if the cause isn't clear. This helps doctors understand the origin, the root of the problem.
Okay, see, E. Next is A.
A for anatomical. This gives a really detailed map of where the problem is. Is it in the superficial veins, the ones closer to the skin? Or the deep veins nestled down in your muscles? Or perhaps the perforating veins, those little connectors that bridge the superficial and deep systems? This segment-based classification is crucial because it helps pinpoint the exact location of the issue, which then guides targeted treatment. You treat the problem where it actually is.
Makes sense. And finally, P.
P for pathophysiological. This explains how the veins are failing. Is it primarily due to reflux, meaning blood is flowing backward because of those faulty valves we talked about? Is it obstruction, where blood flow is actually blocked or significantly hindered? Or is it a combination of both, which definitely happens? Having this level of detail, this structured language, ensures that clinicians anywhere in the world can communicate precisely about your condition. And that's just vital for effective diagnosis and planning the right treatment.
Absolutely essential for good care. Now that we know how to describe it, let's talk about how common this actually is. How common is chronic venous disease? You might be genuinely surprised by just how prevalent it is. There was a big systematic review, looked at data from over 300,000 adults, and it found that about 19% had varicose veins, so that's C2 disease, and a smaller but still significant 0.4% had active venous leg ulcers, C6 disease.
19% with varicose veins, that's nearly 1 in 5 adults.
Exactly. And in Europe, specifically, the prevalence of varicose veins was even higher, closer to 21%. That's a lot of people walking around with these conditions.
It is. And what's really telling here, I think, is not just how common it is, but its progressive nature. You mentioned the Edinburgh vein study earlier. That was a remarkable long-term study. They followed people for 13 years, and it revealed that nearly 1% of adults develop new venous reflux each year. So the problem was starting fresh in people. And here's the real kicker. For patients who started out with just uncomplicated varicose veins, C2 disease, a staggering 1/3, about 33%, went on to develop more advanced skin changes, C4 disease, over that 13-year period.
Wow, a third. That really highlights it, doesn't it?
It really does. It highlights this crucial insight. CVD often isn't static. It frequently gets worse over time, especially if it's left unaddressed or untreated. Understanding this progression is key, really, to appreciating why early intervention, when it's appropriate, can be so beneficial in the long run.
So who is more at risk for this progression then? Who should be particularly mindful? The guidelines list several commonly reported risk factors. These include female gender, increasing age, obesity. Those seem pretty common for many conditions. Also, occupations that involve prolonged standing, a positive family history, so if your parents had it, and parity, which refers to the number of pregnancies a woman has had. Understanding these factors can help you gauge your own personal risk, can't it?
Absolutely. Knowing your risk profile is definitely empowering.
Now, let's delve into something that I found genuinely surprising. As we peek at the anatomy and pathophysiology, what's actually happening inside your legs. Imagine your veins like a complex, multi-layered road network. We have the superficial veins lying closer to the surface, kind of between the skin and the muscles. Then there are the deep veins, found nestled deep within or even inside your muscles. And finally, the perforating veins, acting like connectors, bridging the superficial and deep systems. Key players in the superficial system, the ones often implicated in CVD, include the great saphenous vein, the GSV, and the small saphenous vein, the SSV.
Right. But these guidelines, interestingly, they actually go a step further. They highlight the importance of the microcirculation. We're talking about those tiny veins ranging from microscopic up to maybe 2 millimeters in diameter, found right there in the skin. Historically, it was often thought these really small vessels didn't even have valves. But detailed studies, using advanced techniques, have actually shown that even these tiny microvenous vessels possess valves. And importantly, their failure, their incompetence, can play a critical role in the progression of those visible skin changes we see in C4 disease, sometimes even independently of what's happening in the larger veins. It's a key insight into how the disease manifests right at the skin level.
That's fascinating, the idea of valves in such tiny vessels.
It is. Now let's break down the pathophysiology, what's actually going wrong. In the larger veins, like the saphenous veins, the core problem is usually valve incompetence. Those one-way valves designed to push blood back up to the heart become leaky. This leads to reflux blood flowing the wrong way, pooling, and increasing pressure within the vein. Think of your vein walls, they're normally elastic. But with CVD, they start to lose that stretchiness. They undergo vascular remodeling. They lose elastin, kind of old, worn-out rubber bands. They become weak and baggy. This ultimately leads to the formation of those visible, tortuous varicose veins. And this whole process often starts with inflammatory phenomena, maybe initial irritation or injury to the vein lining.
Okay, so that's the larger veins. What about the deep ones?
In the deep veins, the pathophysiology is often a bit different. It frequently stems from a previous deep vein thrombosis, a DVT. A DVT can lead to either obstruction, where the vein remains blocked or significantly narrowed, or it can damage the valves, causing reflux, or sometimes, unfortunately, both. This state, this aftermath of a DVT, can result in what's known as post-thrombotic syndrome, or PTS. That's a chronic condition where blood just can't effectively leave the limb, leading to sustained increased venous pressure and often quite severe symptoms.
And the skin itself. The microcirculation.
Right. In the skin and microcirculation, the primary driver of the damage we see in CVD is that sustained high pressure in the tiny vessels, venous hypertension. When the pressure gets too high for too long, the small valves in the venules fail. Capillaries dilate, they stretch out. This leads to a whole cascade of events. Fluid leaks out into the tissues, inflammatory mediators are released, immune cells migrate into the surrounding tissue. The result: swelling, chronic inflammation, and that deteriorating sequence of skin changes, discoloration, hardening, lipodermatosclerosis, and eventually the loss of skin integrity and the formation of venous leg ulcers. This intricate connection, this link between the problems in the big veins and these micro changes in the skin, is a truly crucial insight these guidelines emphasize.
That connection is powerful, isn't it?
Yeah.
Linking the macro and the micro. And speaking of pressure, the guidelines mention something called ambulatory venous pressure, or AVP. What's that about?
AVP is essentially a direct measurement of venous pressure in your foot. It's measured when you're standing still and then, crucially, while you're walking. Normally, when you walk, your calf muscles squeeze the veins, that's the calf muscle pump, and this action should significantly lower the venous pressure in your foot. Failure to adequately lower this pressure while walking, that inability to clear the blood effectively, is strongly associated with the higher clinical classes of CVD, like C4, C5, C6. It indicates a more severe condition of breakdown in the system. It's a critical objective marker of how effectively or ineffectively your venous system is working. 2. Symptoms, signs, and scoring systems. How do doctors evaluate CVD?
Okay, so we know about the visible signs, like varicose veins. But beyond that, what does chronic venous disease actually feel like for the patient? What are the common symptoms?
Well, the guidelines tell us that symptoms like heaviness, a sensation of swelling, even if it's not always obvious, burning, itching, and general pain or aching are very common. And interestingly, the intensity of these symptoms tends to increase with the higher clinical classes of the disease. So as the CEA class gets worse, the symptoms often do too. You might also experience things like fatigue in the legs, leg cramps, or restless legs, although the guidelines note these are considered less specific to CVD, meaning they could have other causes as well.
Got it. Are there any more specific signs or symptoms doctors look for?
Yes, and this is where some really important diagnostic clues come in. For instance, something called venous claudication is a very particular symptom. It's described as an increasing pain in the leg, usually the calf or thigh, that develops with exercise, like walking, and often limits how far you can walk. It gets better with rest. This is typically caused by an obstruction, a blockage in the major deep veins in the pelvis or the upper thigh, or sometimes by compression of the popliteal vein behind the knee. On physical examination, a doctor might also spot specific visual cues. Things like cross-pubic collaterals, visible veins running across the lower abdomen can indicate a blockage in a major pelvic vein, like the iliac vein. Or in women, seeing vulvar varicose veins can be a pretty clear sign of underlying pelvic venous disorders, where the problem originates higher up. These specific signs really help a clinician narrow down the potential source of the trouble.
Well, CVD is usually chronic. Are there acute complications we should know about?
Yes, although thankfully they're relatively uncommon. It's important to be aware of possibilities like superficial vein thrombosis or SVT. That's where a blood clot forms in a superficial vein, often a varicose one. While it's often localized, an SVT can sometimes extend into the deep veins, which is a more serious situation, deep vein thrombosis, DVT. And in rare cases, it could even lead to a pulmonary embolism, a clot traveling to the lungs. Another critical, though again rare, complication is hemorrhage or bleeding. This can happen if a superficial varicose vein gets traumatized or bursts, especially if the overlying skin is very thin and fragile, like in advanced C4 disease. The guidelines warn that the resulting blood loss can be quite extensive and, in exceptional cases, even life-threatening if not controlled quickly.
Okay, good to be aware of those potential acute issues. Now, you mentioned CVD is often progressive, so just getting that initial CAB snapshot isn't always enough, is it?
Exactly. While the CAP classification is excellent for describing your disease at a specific point in time, it doesn't really measure change or severity very well on its own. So the guidelines emphasize that other tools are used specifically to track changes over time and, really importantly, to evaluate the success of any treatment you might receive.
Right. So beyond that initial CEP description, what are these other tools that doctors use to track progress? How do they actually measure if a treatment is helping you feel better?
Well, one widely used tool is the Revised Venous Clinical Severity Score, or RVCSS. Think of it as a clinical scoring system designed specifically to measure changes in your status after a venous intervention. It looks at factors like pain, swelling, skin changes, ulcer status, and assigns points. A lower score after treatment indicates improvement. It's like a report card showing how much better things are clinically. Then there's the Villalta scale. This one is specifically used to diagnose and assess the severity of post-thrombotic syndrome, or PTS, that condition after a DVT. It evaluates both symptoms reported by the patient and signs observed by the clinician.
And what about the patient's perspective directly?
Ah, yes. Increasingly, the gold standard for evaluating the true success of interventions is shifting towards patient-reported outcome measures, or PROMs. These are validated questionnaires like the Aberdeen Varicose Vein Questionnaire, AVVQ, or the Chronic Venous Insufficiency Questionnaire, CIVIQ. They directly capture your experience, your symptoms, your limitations, your quality of life. It's a really important shift, I think. It recognizes that how you feel, your personal well-being and daily function is ultimately what matters most when deciding if a treatment has been successful, rather than just relying on purely clinical metrics or ultrasound findings. 3. The diagnostic journey. What investigations are needed?
Okay, so moving on to the diagnostic journey. As you might expect, it all starts with a thorough physical examination, doesn't it?
Absolutely. Ideally, this happens with you in a standing position. That allows gravity to fill the veins, making abnormalities more obvious. The doctor will be looking carefully for all those visible signs of chronic venous disease we discussed: spider veins, varicose veins, swelling, skin changes, ulcers. They'll also look for scars from any previous surgeries, which can provide clues, and even those collateral veins that sometimes indicate deeper problems. It's a critical first step, setting the stage for further investigation.
And after the physical exam.
Well, this next point is really a game changer in modern venous care. The cornerstone, the absolute primary imaging modality for diagnosis and treatment planning in almost all cases of suspected or evident chronic venous disease, is the duplex ultrasound, or DUS. Okay, let's unpack that a bit. DUS is a non-invasive imaging technique. It uses sound waves, just like ultrasound for pregnancy. It has effectively replaced older, less reliable methods like handheld Doppler. Why? Because it gives doctors crucial, real-time information. They can see the structure and shape of your veins, the morphology, and critically, they can assess function looking for reflux, that backward flow of blood due to faulty valves, and any obstruction where blood flow might be blocked.
So what specifically can DUS tell the doctor?
A lot. It can precisely detect and map out reflux in the major superficial veins, like the Great Saphenous Vein, GSV, and Small Saphenous Vein, SSV, and even accessory veins. It also identifies incompetent perforating veins, those connectors between the superficial and deep systems. These guidelines actually give doctors clear, more precise criteria now to define when these perforators are failing, looking at flow direction, duration, and diameter, especially near areas of skin change or ulcers. This helps target treatment more effectively.
And what about if someone has had treatment before and the veins come back?
Ah, yes, for recurrent varicose veins, DUS is absolutely vital. It's essential for figuring out why they came back. Did a previously treated vein reopen, which we call recanalization, have new abnormal vessels grown, called neovascularization, or is new reflux developing in other veins that were previously okay? DUS provides this detailed mapping identifying the nature and the source of the recurrence, which is absolutely essential for planning any potential retreatment effectively.
And sometimes the problem isn't just in the leg below the groin, right? You mentioned pelvic issues earlier.
Exactly. If a problem above the groin, in the abdomen or pelvis, is suspected perhaps because of very extensive swelling in just one leg, or severe skin changes, or an active ulcer that's hard to heal, or even visible veins on the abdominal wall, then an additional abdominal DUS is often performed. This specifically looks for issues like compression or blockages in the major veins returning blood from the legs and pelvis, like the inferior vena cava, IVC, or the iliac veins. Problems here can have a profound impact on leg circulation and symptom severity.
What if DLS isn't quite enough, especially for those deeper veins in the abdomen or pelvis?
Good question. When DUS isn't sufficient, or maybe not feasible for investigating deep venous pathology, especially higher up, then cross-sectional imaging offers powerful alternatives. One option is MR venography, or MRV. This uses magnetic resonance imaging, MRI, to create detailed 3D reconstructions of the venous system. It can be great for visualizing deep vein obstruction and mapping out collateral veins, and it can even provide some dynamic flow information. A big advantage is it doesn't use X-ray radiation or typically require iodinated contrast dye. The other main option is CT venography, or CTV. This uses computed tomography, a CT scan. It's generally more widely available than MRV in many centers. However, CTV does necessitate the use of iodinated contrast dye, which some people can be allergic to or have kidney issues with, and it involves X-ray radiation. So MRV compares favorably in that regard. The choice between MRV and CTV often comes down to local availability, expertise, and specific patient factors.
What about older techniques like venography, injecting dye?
Historically, yes, catheter-based venography, injecting contrast dye directly into the veins and taking X-rays, was considered the gold standard for diagnosing major vein problems. But for chronic venous disease, particularly for initial diagnosis, its role has significantly diminished. For instance, that old technique of injecting dye into a foot vein to screen for deep venous obstruction called ascending venography is now considered largely obsolete. Why? Because duplex ultrasound provides so much detailed anatomical and functional information non-invasively.
But is venography completely out?
Not entirely, but its use is much more selective. However, a newer technique, intravascular ultrasound, or IVUS, has really challenged traditional venography, especially when doctors are evaluating deep venous obstruction with a view to treatment like stenting. IVUS is invasive, yes. A tiny ultrasound probe is put inside the vein, usually during the same procedure where treatment might happen, but studies have shown it's actually more sensitive than venography in identifying and crucially quantifying obstructive lesions, like narrowings or compressions, in those major iliofemoral veins in the pelvis. This superior detail helps clinicians make much better decisions about patient selection for treatments like venous stenting. It can identify subtle compressions or abnormalities in the vein wall that might be missed by other imaging methods.
Are there any other tests mentioned?
The guidelines briefly touch on other functional tests, like plethysmography. Air plethysmography, for example, measures changes in the overall volume of the calf. It can be useful for assessing unexplained leg swelling or perhaps complex cases of post-thrombotic syndrome. It helps quantify the effectiveness of the calf muscle pump and overall venous function, giving doctors another piece of the puzzle in certain situations. 4. Conservative management, first steps in ongoing support.
Okay, so we've talked about diagnosis. Now, when facing chronic venous disease, it's really important to stress again that not every patient immediately needs or even wants an intervention, right?
Absolutely. The guidelines strongly advocate for a robust, conservative approach as the first step, and often as ongoing management too. Simple things, really accessible things, like regular physical exercise, consciously elevating your legs when resting, and maybe even using specialized insoles can make a significant difference for many people. How do they work? Well, they may improve overall mobility, they help strengthen that crucial calf muscle pump we keep mentioning, and they facilitate better venous return, helping blood flow back up toward the heart more effectively.
So practical advice would be?
Promote frequent walks, Really try to avoid prolonged periods of just standing still or sitting. Make a habit of resting with your legs elevated whenever possible, like putting your feet up when watching TV. The guidelines also advise against excessive heat exposure, like very hot baths or saunas, as heat can dilate veins and potentially worsen symptoms. And for obese patients, this is increasingly recognized as critical. Weight loss is considered one of the most important non-interventional contributions to improving CVD and reducing symptoms. It directly impacts that intra-abdominal pressure and helps the calf muscle pump work better. What's more, the guidelines stress a holistic approach. They acknowledge that social and psychological factors can profoundly influence healing, especially when we're talking about venous leg ulcers. Addressing these broader aspects of the patient's life, their support systems, their mental well-being, is crucial for comprehensive care.
That holistic view is so important.
Yeah.
When we talk about conservative management, you mentioned one thing stands out as the absolute cornerstone.
Yes, compression therapy. It's highlighted throughout the guidelines as the cornerstone of conservative chronic venous disease management. The evidence is unequivocal. It's proven effective in relieving a wide array of symptoms: pain, heaviness, cramps, swelling, and it can even help reduce that hardening of the skin, the induration, often seen in more advanced stages like C4 disease.
Can you explain a bit more about how compression works in the different types?
Sure. Compression works by applying graduated pressure. That means the pressure is highest at the ankle and it gradually decreases as the stocking or bandage goes up the leg. This external pressure helps support the vein walls, reduces leakage, counteracts the effects of gravity, and basically aids venous return, pushing blood back towards the heart. It's available in several forms. You have elastic compression stockings, ECS, which are probably the most common, your typical medical grade stockings. Then there are adjustable compression garments, ACG, often using Velcro straps, which allow the patient or caregiver to adjust the pressure. These are increasingly popular. And also inelastic bandages, IB, which provide very firm containment but don't stretch much. These are often used for managing acute swelling or ulcers.
And how effective are these different types?
Well, the guidelines suggest that moderate pressure stockings, typically delivering around 15 to 32 millimillar Hg of pressure at the ankle, are effective for patients with mild to moderate disease, so CEAP classes C1s to C3s. They help with symptoms and control swelling. For more acute or severe swelling, inelastic bandages are very effective initially, but they tend to lose pressure quite quickly as the swelling goes down. Combining them with or switching to adjustable compression garments, which can deliver around 40 millimillar Hg or more and maintain that pressure much more consistently as the leg size changes, are shown to be just as effective or maybe even more so in reducing pitting edema. And importantly, compression therapy has also been shown to reduce that skin hardening, lipodermatosclerosis, in patients with advanced C4b disease.
The benefits seem clear, but let's be honest, wearing compression can be tough, can't it? Compliance must be a big issue.
It's a huge challenge, absolutely. Patients often complain about pain, general discomfort, the sensation of heat, especially in warmer weather, and sometimes skin irritation or itching. And a really big practical barrier is often the difficulty of actually putting the stockings on and taking them off the donning and doffing. This is particularly true for older patients or those who are obese or have arthritis affecting their hands or back. But the good news is there are specialized aids available, things like stocking donor frames, slippery socks that can really help with this. And manufacturers are continually working on new designs and materials to make them easier to use and more comfortable.
Are there situations where compression shouldn't be used? Any contraindications?
Yes, definitely. While many historical contraindications, like minor skin infections or weeping eczema, are no longer considered absolute barriers if proper precautions are taken, like using appropriate dressings underneath, some critical contraindications for sustained high-level compression still remain. The main ones are severe lower extremity arterial disease, meaning very poor blood flow to the feet, usually indicated by an angle-and-cricual index, ABI, below 0.6. Applying high compression here could be dangerous. Severe uncontrolled heart failure, and YHA class 3 or 4, is also generally a contraindication, as the increased fluid return could overload the heart. And of course, a confirmed allergy to the material of the stocking or bandage would preclude its use. These are vital safety checks every clinician needs to make.
Are there other compression methods besides stockings and bandages?
Yes, though they tend to have more limited or specific roles. Intermittent pneumatic compression IPC devices, for example, use inflatable cuffs that wrap around the leg and cyclically inflate and deflate. IPC can be a useful adjunct therapy for reducing swelling or managing symptoms, particularly when sustained compression isn't well tolerated, maybe in some patients with post-thrombotic syndrome, but it's generally not seen as a primary standalone treatment for most CVD patients. There's also neuromuscular electrical stimulation, which aims to stimulate the calf muscles to contract, mimicking the muscle pump, but its use is still quite limited in routine practice.
Okay, that covers physical methods. What about medications? You mentioned venoactive drugs or VADs. Tell us more about those.
Right, VADs. You can think of these as a sort of helping hand for your veins. They're typically plant extracts or synthetic compounds believed to improve venous tone, reduce capillary leakage, and have anti-inflammatory effects. The guidelines suggest that these medications may reduce objective measures of leg swelling, like ankle circumference, and importantly, they can significantly alleviate symptoms like pain, cramps, restless legs, and that subjective sensation of swelling or heaviness.
So should everyone with CVD be taking these?
Not necessarily everyone, but the guidelines take a pretty positive stance. What's interesting is that while some older reviews kind of pooled all VADs together, making it hard to see individual effects, the ESVS guidelines specifically refer to individual meta-analyses that show benefits for specific drugs, like micronized purified flavonoid fraction, MPFF, or Ruscus extract. Given their relatively low costs and the fact that their side effects are generally rare and usually not severe, the guidelines state that VADs should be considered for symptomatic CVD patients. This is especially true if you're not undergoing interventional treatment for whatever reason. Perhaps you're waiting for it, or maybe you continue to experience persistent symptoms even after an intervention. They offer a valuable supportive therapy option to improve quality of life, the interventional treatments. When conservative isn't enough.
Okay, so conservative measures are the foundation. But what happens when those aren't enough? When compression, exercise, and maybe VADs aren't controlling the symptoms adequately,
Right.
That's when interventional treatment comes into play, right?
Exactly. When conservative measures fail to provide sufficient relief for symptomatic chronic venous disease, particularly symptomatic varicose veins, resulting from superficial venous incompetence, so C2S disease or higher, that's when intervention is recommended.
And how is that decision made?
A really key theme that runs through this entire section of the guidelines is shared decision-making. This is crucial. It means your doctor isn't just telling you what treatment you're having. They should be discussing all the available options with you: surgery, different types of ablation, sclerotherapy. They should present the evidence for each, explain the specific risks and benefits as they apply to you, consider local resources and expertise, and crucially, your preferences, your values, your lifestyle, your recovery expectations. These are central to the final decision. It's a partnership.
That partnership approach sounds ideal. And where are these procedures typically done? Do you need to be in a hospital?
Not always, no. For many superficial venous interventions, the guidelines actually advocate for them to be performed in an ambulatory or outpatient setting. This is often feasible and preferred. Frequently, this is done under tumescent anesthesia. That's a type of local anesthesia where a dilute anesthetic solution is injected around the vein being treated. This technique makes the procedure safer, less need for general anesthesia, more effective, protects surrounding tissues from heat and constricts the vein, and generally allows for an early return to your normal daily activities, often the same day or the next day.
What about after the procedure? You mentioned compression earlier.
Yes, following most superficial venous interventions, compression is usually applied. Often this involves placing eccentric pads, like foam or gauze rolls, directly over the treated vein segment, held in place by bandages or stockings. The goal here is to minimize inflammation, reduce pain and bruising, hematoma, and potentially lower the risk of blood clots, like superficial or deep vein thrombosis, DVT. Regarding thromboprophylaxis, giving medications like blood thinners to prevent clots, the guidelines recommend an individualized risk assessment for venous thromboembolism, VTE. However, based on current evidence, routine preventative blood thinners for low-risk patients undergoing standard endovenous ablation procedures is generally not supported. Instead, consistent strategies like encouraging early walking and ambulation, along with continued compression therapy, are always beneficial and recommended for reducing thrombotic risk in basically all patients after these procedures.
Okay, so let's get into the specific interventions for faulty superficial veins. The goal is to close or remove them. What are the main options?
There's quite a toolbox now. The choice really depends on the specific vein involved, its size, how deep it is, where it is, and various patient factors. But the guidelines are pretty clear on the first-line recommendation. Endovenous thermal ablation, or EVTA. This includes both endovenous laser ablation, EVLA, and radiofrequency ablation, RFA. These are recommended as the primary option for treating incompetent great or small saphenous veins. Why? Because they use heat energy delivered via a catheter inside the vein to seal the faulty vein shut. They offer excellent long-term results and are generally considered cost-effective compared to traditional surgery.
Are laser and radiofrequency pretty similar in outcomes?
Yes, current evidence suggests EVLA and RFA have similar efficacy. Both demonstrate high rates of vein closure, often over 90% even at 5 years, and lead to significant improvements in both clinical severity scores, like the RVCSS, and patient-reported quality of life. In terms of long-term recurrence, at 5 years, the overall clinical recurrence rates seem comparable between EVTA and traditional high ligation and stripping HLS surgery. Interestingly, though, the reason for recurrence might differ. Recanalization, where the treated vein reopens, might be slightly more common after EVT, while neovascularization, the growth of new abnormal vessels, might be more common after HLS, especially in the groin. Complications can occur with EVT, like endothermal heat-induced thrombosis, ET, which is basically a clot extending from the treated vein into the deep system, but serious events like DVT or PE are rare, typically less than 1%.
What if someone isn't keen on heat-based methods or maybe can't have tumescent anesthesia? Are there alternatives?
Yes, absolutely. For those who prefer avoiding heat or perhaps the multiple needle sticks of tumescent anesthesia, newer options known as non-thermal, non-tumescent NTNT techniques are available and gaining traction.
Okay, tell us about those.
Well, one that's really generating buzz is cyanoacrylate adhesive closure, or SHAC. This is where it gets really interesting. It literally uses a medical-grade superglue delivered via a catheter to seal the vein shut. Clinical trials, including long-term follow-up, have shown that CAC is essentially non-inferior, meaning just as effective as RFA in terms of closing the vein and improving quality of life. The closure rates seem stable over time. The main adverse event specific to CAC seems to be a local inflammatory reaction, sometimes called phlebitis, which might occasionally be a hypersensitivity reaction to the adhesive itself. But this is usually transient and managed conservatively. A key advantage is often less post-procedure bruising or pain compared to thermal methods.
Or glue.
Yeah.
What else?
Another major NTNT option is ultrasound-guided foam sclerotherapy, or UGFS. This involves mixing a liquid sclerosant chemical with air or gas to create a foam, which is then injected directly into the varicose veins under ultrasound guidance. The foam irritates the vein lining, causing it to spasm, scar, and close off. UGFS is appealing because it's relatively cheap, it's technically easy to perform in an outpatient setting, requires no tumescence, and can be repeated if necessary. However, the guidelines clearly state that UGFS is substantially less effective than EVTA, RFA, or surgery for closing the main saphenous trunks, especially larger ones. The recommendation is generally to use it only for GSV diameters less than 6 millimeters if aiming for primary trunk closure, but it remains a very good option for treating smaller varicose tributaries, residual veins after other procedures, or sometimes as a primary treatment when other options aren't feasible or desired. There's also catheter-directed foam sclerotherapy, CDFS, which might improve occlusion rates over standard UGFS for trunks.
Any other non-thermal options?
Yes, there's also mechanochemical ablation, or MOCA. This technique uses a special catheter with a rotating wire tip that physically abrades or damages the vein lining while simultaneously injecting a liquid sclerosant chemical. So it's a combination of mechanical and chemical ablation, hence the name. MOCA is considered safe and effective, avoids heat and tumescence, and patients often report less pain compared to RFA immediately after the procedure. However, some studies suggest that the occlusion rates at 3 years might be slightly inferior to EVTA, particularly for larger diameter veins. So the initial size of the vein might influence its long-term success compared to heat-based methods.
What about the traditional surgery, high ligation and stripping, HLS? Is there still a place for it?
Yes, there is. HLS was the gold standard for decades, remember? It involves surgically tying off the main superficial vein at its junction with the deep system, ligation, and then physically removing the vein, stripping. Modern HLS techniques can now often be performed under local or tumescent anesthesia, making general anesthesia less mandatory than in the past. The guidelines state that HLS remains a good option if endovenous thermal ablation isn't available or perhaps suitable for a specific patient. As we mentioned, it offers comparable 5-year clinical outcomes to EVTA. However, compared to the newer endovenous methods, HLS may have slightly higher rates of postoperative complications like bleeding, wound infection, and nerve injury leading to numbness or tingling, paresthesia.
Okay, that covers the main trunk veins. But often people have those lumpy veins branching off, or spider veins. How are those dealt with?
Good point. Treating the main source of reflux is key, but often you need to address the visible tributaries as well. For visible varicose tributaries, ambulatory phlebectomy, or AP, is a common and effective technique. It involves removing these veins through multiple tiny incisions, usually under local anesthesia. It gives immediate cosmetic results. As a minimally invasive alternative, especially for smaller tributaries or reticular veins, sclerotherapy using either foam or liquid chemical is widely employed. What about incompetent perforating veins, PVs, those connectors? If they are deemed clinically significant, especially near skin changes or ulcers, treatment options include endovenous ablation, laser or RFA, surgical division or ligation, or often UGFS, which is a common low-cost approach for PVs. And finally, for those very small reticular veins and telangiectasias, what most people call spider vein sclerotherapy, usually with liquid sclerosant, is considered the gold standard treatment. Transcutaneous laser, TCL, where laser energy is applied through the skin surface, is also an option, particularly for very fine telangiectasias, especially on the face or resistant leg veins, but it can sometimes be more painful than sclerotherapy and may require multiple sessions. The choice often depends on the vein size, location, skin type, and clinician expertise.
It sounds like there are options for almost every type of problem vein. But what about unusual situations? Like really large veins or veins in odd places?
The guidelines do address some special anatomical considerations. For instance, for very large saphenous trunks, say over 12 millimeters in diameter, EVTA should still be considered, perhaps using higher energy levels or specific techniques like double catheter passes. For very superficial trunks lying close to the skin, there's a higher risk of skin pigmentation or hardening in duration after thermal ablation, so techniques like CAC or Messier might be preferred, or extra care with tumescence is needed. For saphenous trunk aneurysms, localized bulges, EVTA combined with ligation or just EVC alone may be effective depending on the size and location. Even really unusual locations like incompetence in a persistent sciatic vein, a rare developmental variant, or intraosseous perforating veins connecting directly to bone marrow, have specific treatment approaches suggested, often involving UGFS or phlebectomy.
Now, let's circle back to something you mentioned earlier, recurrent varicose veins. This must be a common and frustrating problem for patients.
It absolutely is. It's a significant challenge in venous practice. Recurrence after treatment can happen for several reasons, and understanding the cause is key to managing it. It might be due to tactical errors, maybe the initial diagnostic ultrasound wasn't thorough enough, or an inappropriate treatment choice was made for the specific anatomy, or technical errors during the procedure like incomplete ablation or stripping of the target vein. Then there's neovascularization, the actual growth of new, abnormal, reflexing vessels, particularly common in the groin after traditional HLS surgery. Conversely, recanalization, the reopening of a previously treated and closed vein, is seen more often after endovenous ablation techniques like EVTA or even sclerotherapy. And finally, simple disease progression can occur, where new reflux develops over time in veins that were perfectly healthy at the time of the initial treatment.
So if someone has recurrent veins, do they need another big operation?
Not necessarily, and this is a key point in the updated guidelines. The good news is that less invasive approaches, like repeat EVTA or UGFS, performed without needing to surgically re-explore scarred areas like the groin or the space behind the knee, popliteal fossa, are now strongly advocated. These endovenous or minimally invasive techniques are considered safe and effective alternatives to redo open surgery for managing most cases of recurrent varicose veins. This helps avoid the significantly higher complication rates often associated with reoperating through dense scar tissue.
Okay, that covers the superficial system in quite some detail. What about when the problem is in the deep venous system? That sounds more complex.
It generally is, yes. When the primary problem lies in the deep veins, it's often more serious and frequently linked to that debilitating condition we mentioned earlier, post-thrombotic syndrome, or PTS, which develops after a DVT.
Remind us about PPS again.
PTS is a chronic condition characterized by symptoms like leg pain, persistent heaviness, chronic swelling, edema, skin discoloration, and potentially leading to severe skin hardening and venous leg ulcers. It can really impair quality of life. For PTS, conservative treatment is always the first line. This includes supervised exercise training programs to strengthen the calf pump and consistent long-term compression therapy. However, for patients who have severe symptoms, disabling pain, severe swelling, non-healing ulcers that significantly impact their quality of life despite good conservative management, then endovenous or sometimes surgical techniques are carefully considered.
What kind of interventions are we talking about for deep vein problems?
The main focus for intervention in the deep system is often on iliocaval and iliofemoral obstruction. These are blockages or significant narrowings in the major deep veins in the pelvis, iliac veins, and upper thigh, femoral vein, or even the inferior vena cava, IVC, in the abdomen. For patients with severe symptoms related to these obstructions, like disabling venous claudication or non-healing ulcers, endovascular treatment, specifically venous stenting, is now considered the first choice.
Venous stenting. How does that work exactly, and what are the outcomes like?
Venous stenting involves inserting a catheter, usually from the groin or behind the knee, up to the point of blockage under X-ray guidance. Then, a self-expanding metal mesh tube, the stent, is deployed across the narrowed or blocked segment to prop the vein open and restore normal blood flow towards the heart. Remember, IVUS, intravascular ultrasound. The guidelines strongly suggest considering IVUS during the stenting procedure. It gives the operator a precise view from inside the vein, helping to accurately identify the extent of the blockage, choose the right stent size, and ensure optimal placement, which is crucial for good long-term results. Stents are used to reopen these blocked veins. The success rates, in terms of keeping the vein open patency, are generally quite good, often reported as 95–100% for non-thrombotic lesions, like May-Thurner compression, and maybe 70–80% or higher at 1 to 2 years for post-thrombotic obstructions, although long-term patency can be lower in PTS cases.
And does it help patients feel better?
Yes, significantly. Successful stenting can lead to marked improvements in clinical scores like the RVCSS and the Villalta scale for PTS. It often reduces pain and swelling substantially, and critically, it can significantly aid in the healing of venous leg ulcers that were resistant to other treatments. Because these are complex cases, often involving decisions about blood thinners and long-term follow-up, the guidelines strongly suggest management by a multidisciplinary team, ideally involving an interventional radiologist, a vascular surgeon, and maybe a hematologist. What about problems after stenting? Acute stent thrombosis, clotting, or symptomatic narrowing within the stent in stent stenosis can occur, although rates are improving. These situations may require reintervention, often involving techniques to remove the clot, thrombolysis, or thrombectomy, or sometimes additional stenting. What about traditional surgery? Surgical bypasses like the Palma bypass, creating a detour using a vein from the other leg, or hybrid procedures combining stenting with surgical removal of old clot, called endophlebectomy, are now rarely performed. They are reserved only for very select cases, perhaps recalcitrant ulcers or disabling claudication, where endovascular options have failed or aren't possible because these major open surgeries carry higher risks and complication rates.
You also mentioned some rare deep vein conditions earlier.
Right, like popliteal vein aneurysm and entrapment. These are uncommon, but important. Popliteal vein aneurysms, those bulges behind the knee, if they're large or causing symptoms like pain or thromboembolic complications, clots breaking off, may require surgical repair, like removing the aneurysm and reconstructing the vein. Popliteal venous entrapment syndrome, often seen in young, athletic individuals, involves extrinsic compression of the popliteal vein, usually by surrounding muscles or tendons during certain movements. This can cause exercise-induced leg swelling, pain, and sometimes venous claudication. Diagnosis can be tricky, often requiring dynamic imaging. Management ranges from conservative measures to surgical decompression if symptoms are severe.
What if someone has problems in both the superficial and deep veins? That sounds really complicated.
It is tricky. This requires very careful evaluation and strategic planning. If you have both superficial reflux and deep venous reflux, treating the superficial reflux first, for example, with EVTA, can sometimes actually correct or improve the segmental deep venous reflux, possibly by reducing the overall venous load. However, if significant deep vein obstruction is present alongside superficial reflux, the situation changes. Doctors must carefully determine if those superficial veins are acting as crucial collateral bypasses, essentially providing an alternative route for blood to get around the deep blockage. In such cases, ablating those superficial veins could actually worsen the patient's symptoms. So the general consensus reflected in the guidelines favors a staged approach. Treat significant deep venous outflow obstruction, like with stenting first, then address the symptomatic superficial reflux, and only then, if severe symptoms persist, consider interventions specifically targeting deep venous reflux, like valve repair surgery, which is complex and rarely done. It really highlights the need for a highly individualized strategy based on detailed assessment. Management of venous leg ulceration, VLU, the most severe form.
Okay, let's focus now on the most severe manifestation of chronic venous disease. Venous leg ulceration, or VLU. These are the open sores, typically around the ankle, classified as CEA C6.
And VLUs represent a huge burden both for the individual patient and the healthcare system. They are unfortunately common. They are notoriously expensive to treat due to the need for dressings, nursing care, and potential hospitalizations. And they have that frustratingly high recurrence rate we mentioned, up to 70% recurring within just 3 months after initial healing. It's a persistent, challenging problem that dramatically impacts quality of life.
Given that burden, how should VLUs be managed?
Specialist care, often delivered by a dedicated wound care clinic or a multidisciplinary team, is absolutely crucial for optimal outcomes. These teams typically follow structured approaches to wound care, often summarized by the TIME principles, addressing non-viable tissue, debridement, managing infection or inflammation, ensuring proper moisture balance in the wound bed, and promoting wound edge advancement for healing. Pain control is also paramount for these patients. Ulcers can be very painful, and managing that pain effectively, perhaps using topical anesthetics like EMLA cream before procedures like debridement, is essential for patient comfort and cooperation with treatment.
What about infection? You'd think ulcers would get infected easily. Aren't antibiotics standard?
That's a common assumption, but surprisingly, the guidelines state that routine use of systemic antibiotics, pills or IV, for clinically uninfected VLUs is not recommended. Overuse contributes to antibiotic resistance. Antibiotics are reserved for clear clinical signs of spreading infection. However, managing the bacterial load in the wound itself is important. Topical antiseptics like cadexamer iodine or certain silver-containing dressings do show some promise in reducing bacterial burden and potentially aiding healing, although the evidence isn't always robust.
What about cleaning the wound, debridement, and the dressings themselves? There seem to be so many options.
There are indeed numerous methods for debridement, removing dead or unhealthy tissue from the wound base. This can be done surgically with a scalpel, mechanically with gauze or hydrosurgery, using enzymatic ointments autolytically, using the body's own enzymes under moist dressings, or even biosurgically using sterile medical maggots. Similarly, the market is flooded with a vast array of advanced wound dressings, foams, hydrocolloids, alginates, hydrogels, etc. However, what's fascinating and perhaps a bit humbling for the field is that despite all these options, the current evidence, as reviewed by the guidelines, is surprisingly limited on whether any specific debridement method or any particular type of advanced dressing significantly improves VLU healing compared to simpler, less expensive options, as long as the core principles of wound bed preparation and moisture balance are followed. So the focus really remains on those foundational principles, keeping the wound clean, managing exudate, protecting the surrounding skin, and applying effective compression rather than searching for a single miracle dressing.
Speaking of compression, how vital is it for ulcers?
For venous leg ulcers, compression therapy is absolutely king. The guidelines state unequivocally that it is the most effective single conservative treatment. It demonstrably improves healing rates and also helps reduce the associated pain. Without adequate compression, VLU healing is significantly impaired.
What kind of compression is best for ulcers?
For active VLU healing, the guidelines generally prefer systems that can exert and maintain high pressure, typically 40 millihg or more at the ankle. Inelastic bandages, like multi-layer short-stretch systems, or adjustable compression garments, ACG, are often favored because they provide firm containment and maintain their pressure effectively, even as the leg swelling changes during the day, or as the ulcer heals. For smaller, more recent ulcers, superimposed elastic compression stockings, wearing 2 layers to achieve 40 mmHg, can be a good and perhaps more manageable alternative for some patients. The critical point, though, is achieving that sustained high pressure safely. And, crucially, compliance with long-term compression therapy, even after the ulcer has healed, is absolutely vital to prevent recurrence. That's often the hardest part.
What if someone have both vein problems and artery problems, mixed ulcers?
That's an important consideration. For these mixed arterial venous ulcers, standard high compression might compromise already poor arterial blood flow. So in these cases, modified compression, delivering less pressure, typically 40 mmHg is considered, but only if the ankle blood pressure is deemed adequate, usually an ABI 0.6, and the patient is closely monitored for any signs of worsening arterial circulation.
Okay, compression is key. But what about treating the underlying vein problem itself when there's an active ulcer?
This is another area where the guidelines have become much clearer and more proactive. Beyond compression and wound care, addressing the underlying venous incompetence is crucial for durable healing. For active venous leg ulcers that are associated with proven superficial venous incompetence, like reflux in the GSV or SSV, the guidelines now strongly recommend early endovenous ablation, ideally performed within 2 weeks of initiating compression therapy. Why so early? Because studies like the EVRA trial have shown that this prompt intervention significantly accelerates ulcer healing and, very importantly, substantially reduces ulcer recurrence rates compared to compression alone, followed by delayed ablation. This holds true even if some deep venous incompetence is also present.
So treat the superficial veins quickly, even if the ulcer is open.
Yes, that's the key takeaway. Additionally, ablation of smaller abnormal veins located directly under the ulcer bed, often using ultrasound-guided foam sclerotherapy, UGFS, may also be considered as part of a comprehensive strategy to improve the local venous environment and promote healing. And as we discussed earlier, for active or even healed VLUs where a significant blockage in the major pelvic veins, iliac vein outflow obstruction, is identified, venous stenting should be considered to improve venous drainage from the limb. This really underscores that critical point. Merely treating the wound's surface often isn't enough for long-term success. Identifying and correcting the underlying venous hemodynamic problems significantly improves healing outcomes and drastically reduces the risk of those debilitating ulcers coming back.
And finally, pharmacotherapy for ulcers. Do VADs help here too?
Yes, venoactive drugs, the ones we discussed earlier for general CVD symptoms, also appear to play a useful adjunctive role in VLU management. The guidelines cite evidence suggesting that certain VADs, like MPFF, hydroxyethyl HR, sulodexide, and pentoxifylline, have shown benefits in accelerating VLU healing when used alongside standard care, which includes compression and local wound therapy. They don't replace compression or necessary interventions, but they can offer a valuable supportive role, potentially helping the wound to close faster for some patients. 7. Pelvic venous disorders causing varicose veins, a specific focus.
Moving on to something really interesting, an entirely new chapter in the 2022 guidelines. Pelvic venous disorders causing varicose veins. This acknowledges that sometimes those troublesome varicose veins you see in the legs actually have a hidden origin, not just in the leg itself, but deeper, originating from problems within the pelvis. This new focus reflects a growing understanding of the body's interconnected venous system, doesn't it? And it feels like a potential game changer for patients who might have previously been misdiagnosed or struggled with recurrent veins despite leg treatments.
Absolutely. It's a significant addition. What's particularly insightful here is the introduction of the new SVP classification. This system is designed specifically to help categorize pelvic venous disorders, or PVD, more clearly and consistently. It looks at 3 key components: symptoms like pelvic pain or pain during intercourse, visible varices, where are the abnormal veins located, pelvic, vulvar, leg, and the underlying pathophysiology across 4 distinct anatomical zones within the abdomen and pelvis, gonadal veins, iliac veins, etc. This allows for a much more precise understanding and communication about these often complex conditions, especially when they are linked to varicose veins appearing in the lower limbs.
What kind of underlying problems in the pelvis can lead to leg veins?
Well, PVD can be associated with specific pathologies. One well-known example is May-Thurner syndrome, also called iliac vein compression syndrome. This is typically where the left common iliac vein gets compressed between the overlying right common iliac artery and the spine. This compression can cause blood to back up and find alternative routes, often leading to reflux down into pelvic veins and subsequently into the legs. Another condition is nutcracker syndrome, where the left renal vein coming from the kidney gets compressed, usually between the aorta and the superior mesenteric artery. This increased pressure in the renal vein can also lead to reflux into pelvic veins, like the ovarian vein, and potentially cause pelvic congestion symptoms or leg varicosities.
So how might you or your doctor suspect that leg veins have a pelvic origin? What are the clues?
You should think about a potential pelvic origin if you have atypical patterns of leg varicose veins, perhaps veins appearing on the inner thigh or back of the thigh that don't seem connected to the main saphenous veins. Also, seeing vulvar varicose veins is a strong indicator. And importantly, experiencing recurrent varicose veins after previous, seemingly adequate treatment of the leg veins, especially if the main saphenofemoral junction in the groin appears competent on ultrasound, should raise suspicion. Pelvic pain, particularly chronic pelvic pain, heaviness, or pain related to menstrual cycles or intercourse, dyspareunia, is also a key symptom of pelvic venous congestion, though it's actually less common in patients whose only complaint is leg varicose veins originating from the pelvis.
How are these pelvic conditions diagnosed?
The diagnostic journey for suspected PEVD usually starts with that thorough duplex ultrasound of the entire leg, paying special attention to potential pelvic escape points, perforating veins in the groin, buttock, or perineal regions where pelvic veins might be draining downwards into the leg veins. If PEVD is suspected based on symptoms or DUS findings, then further imaging is needed. Abdominal and/or transvaginal ultrasound, TVUS, are often considered first line. These can identify dilated ovarian veins, often defined as 5 mm, or varicocele within the broad ligament or around the uterus. Cross-sectional imaging like CT venography or MISAR venography can also be very useful for visualizing the pelvic venous anatomy and identifying compression points like May-Thurner. However, selective venography, which involves threading a catheter into the pelvic veins and injecting contrast dye under X-ray, remains the gold standard diagnostic procedure, especially before any embolization treatment is planned. It allows for direct visualization of the anatomy, confirms reflux, measures pressure gradients, and can be immediately followed by intervention in the same session.
Okay, let's talk treatment. This sounds like a nuanced area, especially regarding whether the patient has pelvic pain or just leg veins.
It is very nuanced, and the guidelines provide important clarity here. For patients who have varicose veins clearly originating from a pelvic source, identified escape points, pelvic reflux, but who do not have significant pelvic symptoms, like chronic pain impacting quality of life, the recommendation is that local procedures should be the initial therapeutic approach. What does that mean? It means treating the visible leg varicose veins themselves, perhaps with phlebectomy or foam sclerotherapy, and potentially treating the related pelvic escape points where they connect to the leg system, often with UGFS.
So don't jump straight to treating the pelvic veins themselves in that case.
Exactly. This is a really important distinction the guidelines make. Pelvic vein embolization, which is a more extensive procedure involving blocking off the refluxing pelvic veins, like the ovarian or internal iliac ones with coils or plugs, should not typically be performed as the initial treatment in these patients who only have leg symptoms. Why? Because the benefit of pelvic vein embolization for solely treating the leg varicose veins in the absence of significant pelvic symptoms isn't reliably established by strong evidence yet. The focus should be on the leg manifestation first.
But what if the patient does have significant pelvic symptoms?
That changes the picture. For patients who have varicose veins of pelvic origin and suffer from significant pelvic symptoms like chronic pelvic pain, heaviness, or dyspareunia that demonstrably impacts their quality of life, then pelvic vein embolization is considered the current standard interventional procedure. Embolization aims to block off the main sources of reflux within the pelvis, typically the incompetent gonadal, ovarian, or testicular veins, and sometimes branches of the internal iliac veins. This approach has shown high technical success rates and often leads to significant reduction in pelvic symptoms. Of course, in these complex cases involving pelvic pain, collaboration with other specialists like a gynecologist or a urologist is crucial to rule out other potential non-venous causes of the pain before proceeding with embolization.
What about pregnancy? Varicose veins are common then.
Yes, for pregnant patients who develop leg or vulvar varicose veins, often due to hormonal changes and pressure from the growing uterus, conservative treatment is generally advised. This means good quality compression hosiery and regular leg elevation. Interventional treatments are typically deferred until several months after delivery, allowing time for hormonal levels to normalize and venous changes to potentially regress. Reevaluation is needed postpartum if symptoms or significant varicosities persist. Exceptions might be made for acute complications like bleeding or extensive thrombosis during pregnancy, but that's rare. 8. Special patient characteristics tailoring treatment.
The guidelines also dedicate space to how treatment might need tailoring for patients with specific characteristics. Let's start with obesity. We know it's a risk factor, but how does it affect treatment?
Obesity is definitely a major contributor to CVD severity. That extra weight increases intra-abdominal pressure, which can directly impede venous return from the legs, and it can also impair the efficiency of the calf muscle pump. So what's insightful here is the strong recommendation, again, for weight loss. It's considered one of the most important non-interventional factors for improving venous outcomes in obese patients. It can significantly reduce symptoms and potentially slow disease progression. If an intervention for faulty superficial veins is needed in an obese patient, endovenous ablation, EVTA or NTNT, is generally preferred over traditional open surgery, HLS. Why? because studies show lower rates of wound complications, infections, and potentially VTE in obese patients with endovenous approaches compared to open surgery. That said, performing endovenous ablation can sometimes be technically more challenging in obese individuals because the veins are often deeper beneath the skin surface, making ultrasound visualization and catheter access potentially more difficult.
What about pregnancy? We touched on it regarding pelvic veins, but any other points?
Just to reiterate, pregnancy itself commonly increases the frequency and severity of varicose veins, spider veins, and general leg edema due to hormonal effects and the physical pressure of the uterus. Conservative measures, especially properly fitted compression stockings and regular leg elevation, are the mainstay of management during pregnancy. Interventions are typically deferred until well after delivery unless significant complications arise, like a major superficial vein thrombosis or bleeding.
What if a patient is already on anticoagulants or blood thinners for another reason, like atrial fibrillation or a past DVT? Can they still have venous procedures?
Sure. This is a common clinical question, and the guidelines provide welcome clarity. The good news is that therapeutic anticoagulation is generally not considered a contraindication for performing endovenous thermal ablation, EVLA or RFA. What's more, the guidelines explicitly state that the routine interruption of anticoagulation for these procedures is not recommended. Stopping blood thinners might paradoxically increase the risk of bleeding complications during the procedure due to rebound effects, or potentially decrease the treatment's efficacy if thrombus forms around the ablation site. So, generally, procedures can be done safely while continuing anticoagulation, perhaps with minor dose adjustments in some cases.
That's helpful. What about elderly patients or those with multiple other health problems, comorbidities?
This group is increasingly common in venous practice as CVD prevalence rises with age. The positive message from the guidelines is that endovenous thermal ablation, particularly when performed under local or tumescent anesthesia, has been shown to be safe and effective in older patients, even those with significant comorbidities. Studies show comparable rates of efficacy, vein closure, and safety, low complication rates, to younger patient cohorts. So age itself shouldn't be a barrier to offering effective treatment if the patient is symptomatic and suitable. However, it is worth noting that some studies suggest advanced age might be a statistically significant risk factor for slightly higher rates of recanalization, vein reopening, in the longer term after EVTA. It's just something to be aware of during follow-up.
And finally, what about children? Is CVD common in kids?
Thankfully, significant chronic venous disease is rare in children. When it does occur, it's often related to underlying congenital vascular malformations, like Glippel-Trenaunay syndrome, or perhaps secondary to a previous deep vein thrombosis, which can happen even in childhood. Management in children is predominantly conservative, focusing on compression therapy and managing symptoms. However, for selected older children or adolescents with significant symptomatic superficial venous incompetence, endovenous laser ablation, EVLA, has been reported in small series as being feasible and safe, offering a less invasive alternative to surgery when intervention is deemed necessary. 9. Gaps in evidence and future perspectives, what we still don't know.
We've covered an incredible amount of ground reflecting the depth of these guidelines. But despite all this progress, the document is also refreshingly honest about what we still don't know, isn't it?
It really is, and I think that's a sign of a mature scientific document acknowledging the limits of current knowledge. There are significant gaps in the evidence that future research urgently needs to address. It reminds us that medicine is always evolving.
What are some of the big unanswered questions?
Oh, there are quite a few highlighted. What's truly striking is how much remains to be understood about the nuances and long-term trajectory of CVD, for instance. We still don't have really strong predictive models to tell us which patients who present with simple C2 varicose veins will be the ones who eventually progress to develop severe C4 skin changes or C6 ulcers. Identifying those at highest risk early on would be hugely valuable. We also lack definitive evidence on the optimal strategic approach for different clinical scenarios. Should treatment choice differ significantly based on vein size, the specific EAP class, or particular anatomical patterns of reflux? We have preferences, but high-level evidence is often lacking. The management of incompetent perforating veins, PVs, is another area needing clarity. When exactly should they be treated? Which ones are clinically relevant? And what's the best method: surgery, ablation, sclerotherapy? More research is needed here.
What about lifestyle factors or deep vein treatments?
Yes, the guidelines point out we need better studies on the true, quantifiable impact of specific lifestyle changes and structured exercise programs on long-term CVD outcomes. We know they help, but quantifying how much and which specific programs is less clear. For deep venous interventions, especially complex iliac vein stenting for PTS or non-thrombotic lesions, developing clearer evidence-based criteria for selecting the ideal patients who will benefit most and predicting long-term stent patency remains a major challenge. And for chronic venous leg ulcers, a really critical clinical question remains. What is the actual benefit of performing superficial venous ablation if the ulcer has already been open for a very long time, say more than 6 months, or even years? Does early ablation offer the same advantage, or are there diminishing returns in very chronic ulcers? We need more data on that specific scenario. Furthermore, for pelvic venous disorders, developing better, validated clinical criteria and scoring systems to define the condition and measure treatment, success is an ongoing effort.
Wow, that's quite a list. It really highlights that this is far from a solved field.
Absolutely. These questions aren't criticisms of the guidelines, they're roadmaps for future research. They show where the frontiers of our knowledge currently lie. These guidelines provide an excellent snapshot of the current best practices based on available evidence, but continuous high-quality research asking these very questions is absolutely vital. It's how we'll refine our understanding, develop even better treatments, and ultimately improve patient care and prevent the progression of chronic venous disease more effectively in the future. Outro.
And there you have it. We've just taken a really comprehensive journey, a true deep dive through the ESVS 2022 Clinical Practice Guidelines on Chronic Venous Disease of the Lower Limbs. We explored how precise classification using systems like CEEP, advanced diagnostics, especially duplex ultrasound, but also things like IVUS, and a really wide array of both conservative and interventional treatments are revolutionizing care. And importantly, always with that strong emphasis on shared decision-making between doctor and patient.
Yeah, I think what really stands out here and what I hope is maybe your aha moment from this discussion is that clear shift towards recommending early intervention for conditions like venous leg ulcers, recognizing that addressing the underlying venous problem quickly, usually with endovenous ablation, can significantly accelerate healing and, crucially, prevent recurrence. It's also the emphasis on a truly personalized approach to treatment, moving beyond maybe older one-size-fits-all solutions, and the growing recognition and evidence for effective non-thermal, non-tumescent options, improving safety and patient comfort. But perhaps the biggest single takeaway for me is appreciating the dynamic nature of venous disease itself. It often progresses, and understanding that progression, understanding the link between the largest veins and those intricate microchanges happening in our skin is absolutely key to effective long-term management.
That's a great summary. So here's a final thought for you, our listener. Considering how prevalent and often progressive chronic venous disease can be, and given those intricate connections between our largest veins and the tiniest vessels in our skin, what hidden health stories might our legs be trying to tell us right now that perhaps we're not yet fully listening to?
It's a good question to ponder. And please remember, while we've worked hard to distill these comprehensive guidelines for you today, they are primarily intended as a guide for medical professionals. If anything we've discussed resonates with you personally, maybe sparks a concern, or if you just have questions about your own venous health, please make an appointment to consult your healthcare professional, your GP, a vascular specialist, whoever is appropriate. They are the only ones who can provide personalized advice based on your individual condition, your medical history, and the resources available locally, ensuring you get the assessment and care that's right for you.
Excellent advice. Thanks so much for joining us on this deep dive today. Until next time, stay curious and stay informed.